next is going to be a symposium on radiology for the internist. There will be three talks. So first, pearls and pitfalls in CT and MRI, a case-based discussion by Dr. Iranga Ganevathe. He's a consultant radiologist, Lady Ridgeway Hospital. May I call upon Dr. Iranga Ganevathe to deliver your speech.
Thank you. Good morning to everyone. Let me thank everybody who is organizing for the kind invitation. And my topic would be to discuss on pearls and pitfalls of CT and MR, which is almost 60% of radiology, which I won't be able to cover in 20 minutes. But I will try and run through some of the interesting cases and some of the basics that we need as the referring physicians you need to understand when you're referring for an investigation, especially CT and MR. Just to understand what CT and MR, I think everybody here do understand what's the basics and principles of it, where CT uses the X-rays. So any patient who's should not undergo any X-rays shouldn't be able to withstand a CT scan, whereas MRI is using a powerful magnetic field where only the magnetic field and the radio frequencies are used, which could be used at any instances where you can't use the CT scans for the diagnosis. And cost-wise, it's quite cheaper to have a CT rather than MR, and the availability in this part of the world also the same, where you hardly find MR scans in our government sector, only in very few major hospitals. But increasingly there have been new scanners are being installed in even places like Badulla now, and so everybody get a chance to have access to get an MR. Just a small thing for MR contraindications. Now, earlier it was said that a lot of people who have these pacemakers and cochlear implants are contraindicated, but with the new advent of new changing into the modalities of these, there are mechanisms, you can use these pacemakers also after some remodification before the scan. Get the slides back. Here, this one. All right, sorry. Right. Just basic preparation. For a non-contrast, you don't need any preparation as far as everybody concerns. But for a contrast, you need at least 6 hours of fasting. Needs to exclude any allergies. If the allergies are there, you need some pre-medication, and you need to have a good renal function since you are giving any contrast, and you need IV access as well. And I'm sure most of us use this old medication for pre-medication, so everybody who's referring always ask, do you have to wait 3 days for a MR or a CT to get with contrast, which is not the case now, and you have new guidelines and ACR guidelines where you use oral methylprednisolone 32 milligrams 12 hours and 2 hours prior with a dose of chlorpheniramine 1 hour prior, which is, so you have to wait at least for 12 hours to get an MR with a contrast. But if you have an emergency where you need to do a contrast study, you need to wait at least 4 hours, because studies has shown that if you give an IV steroid, which is 200 milligrams of hydrocortisone and one chlorpheniramine 1 hour prior, you can do a study with contrast. But studies have shown that if it is less than 4 hours, 4 or 6 hours, they have not been benefited. Moving into a few of the cases that you would come across in the day-to-day practice. So stroke imaging is quite common for everybody. So everybody knows that MR is much superior in early detection of acute stroke, and you don't need any contrast except for perfusion. So it's quite an easy way of getting done, but the only problem is availability as well as it's time consuming, and you need a better cooperation from the patient to have a proper MR image. What are the things that you would see in a hemorrhage? A non-contrast CT would suffice, and where you would see a hyperdense lesion in the brain, and in MR you need the GRE, that is gradient echo imaging, or SWI, where you would see the hemorrhage clearly. And for the infarct, the size of the infarct, which is a practice now where you do perfusion imaging to gain the size of the infarct, that is perfusion imaging, or DWI, because before embarking on thrombolysis or mechanical thrombectomy, you need to know the volume of the infarct, because if the infarct volume is too much, you will end up with a post-treatment hemorrhage. And the penumbra, of course, you can assess with the perfusion CT or MR, which equally well. And if you are thinking of a mechanical thrombectomy, you need to know whether it's a large vessel or small vessel occlusion, where you will see it in a MR without any contrast. But if you do a CT, you need to do a contrast study to see where the block is. And of course, it's quite clear here that the CT images are quite normal for everyone, and the MR, the DWI images has shown clearly where there's a large infarction, which is too early to detect on CT, plain CT imaging. And of course, you need to use diffusion weighting imaging. This is the earliest image that you would see for the infarction diagnosis. And of course, another quite common scenario is where you would get a patient with thundering headache and you suspect of a SAH. You would request initially a non-contrast CT, which is quite freely available, but sometimes it all depends on the timing and as well as the amount of blood in the subarachnoid space for the CT to detect. But if you do an MR, you would see in early as before even like couple of minutes later, you would be able to see the blood in the subarachnoid space, especially using FLAIR imaging, as you see on the right image, where you would see a hyper intensity within the subarachnoid space, which is very subtle on the CT image, if you can see it. So, just one thing to remind, that this part of the world we have different protocols, since just to cut down on cost and the timing. So we request, some of the times we request limited MR protocols, which has limited number of sequences. So if you are thinking of a SH and requesting limited MR brain, be careful, you might miss it, because some of the sequences doesn't have every imaging that would tackle a subarachnoid hemorrhage. So be aware with when you're referring for a limited MR. And there's one more thing that I just wanted to brought it up, and which is called pseudo subarachnoid hemorrhage. In the top images, you would agree with me that it looks like a massive grade 5 subarachnoid hemorrhage. But when you do a contrast study, you would see that there is a lot of enhancement within the Salzkai and the CSF spaces. You think that the patient is having a subarachnoid, and but the clinical setting does not fade, and then ultimately end up doing an MR, which shows that in the FLAIR imaging there was nothing in the subarachnoid space, but you do a SWON imaging, there's hyperemia with increased venous lacules in the subarachnoids. This is purely because of hypoxemic brain damage, then you will get dilatation of the veins. So this is kind of a pseudo subarachnoid hemorrhage. Beware of it, and if the clinical setting is not for a subarachnoid hemorrhage, and you see these images, you might end up ordering a MR for the further information. And another scenario would be to see when you have isodense SDH, everybody would agree that the first image on the left side, it's very difficult to understand where there's a subarachnoid hemorrhage, but you would agree that there's some sort of a cerebral edema setting in. But when you do a contrast study, that you can see there's a subdural hemorrhage separating the dura from the calvarium. And of course, every instance the MR would be superior, and which is easily seen on any image sequences in a MR. Even a limited MR would give a good answer on this matter. So, so what do you think in the first, the image looks like a subarachnoid hemorrhage with some edema? Yeah. Okay, and when you do a bone scan, you would see that there's something funny happening on the posterior aspect of the calvarium. And when you do a 3D, you would see there's a lot of motion artifact. This is a SDH mimic. So when you are getting an image in the first, like an image that you see it on the left hand, make sure that you have a look at the bone scan, then see whether there's a motion artifact which can mimic a SDH. So since we are seeing a lot of printed images in the ward setting, be careful when interpreting some of these cases. So this is purely motion artifact. Another scenario where you would see a cavernoma, which is capillary hemangiomas in the brain, which are not that uncommon in this part of the world. And in the CT, it's very difficult to understand, but if you have a minor hemorrhages, that you would understand that there's in the right frontal basal, you see a slight hyperdensity, but you don't know what it is, and you think it's a ICH. When you do MR image, that you would see a very nice popcorn appearance on T2 imaging with hemosiderin ring. This is a cavernous hemangioma. Venous sinus thrombosis, again, is a common encounter that you would come with clinicians. On the left hand, on the CT, you would see there's a hyperdensity on the transverse sinus and the lower part of the superior sagittal sinus at the back. And if you're not sure, you have to always do a venogram, which will ultimately resolve your diagnosis, and you will see a nice thrombus within the sinus, which is not filling with contrast. And on the top right-hand corner, on the middle image, you would see a thrombosed vein. In the even a non-contrast image, you would see in T1 imaging, when you have a hyperdense blood, you would see it has a increased density, increased intensity. And so one thing to remember in MR brains, that if you see something hyper intense on T1, you either have to have a subacute blood or fat. So it's a kind of an easy way of remembering it. And if you are not sure on these images, then you have to do a venogram, where you would see that there's obviously there's obstruction at some point on the right-hand side. So what are the venous sinus thrombosis mimics, and especially in polycythemia? And you would agree that on the left-hand corner, the transverse sinus looks a bit hyperdense, and in most of the people who are dehydrated or polycythemic, you might end up with seeing these. But if the clinical setting and does not warrant that it's a sinus thrombosis, if you have the suspicion, then of course you have to end up doing a contrast venogram or a CT venogram. And of course, on the middle image, you would see there's a hyperdensity along the superior sagittal sinus, and this can mimic a venous sinus thrombosis, but in fact, this is a subdural hemorrhage. And of course, it's quite difficult on this setting, only this image, but if you see, there should be other part of the subdural hemorrhages associated, especially along the tentorium. So where you would look for venous infarctions in the territories, you would understand this does not look into a arterial territory that you can see along on the either side of the superior parietals. You will see when you have a superior sagittal sinus thrombosis, and when you have an internal cerebral vein thrombosis, you will have a basal ganglia thalamic infarction, and on the temporal lobes, when you have a thrombosis of the biggest superficial vein on the back, which is called the vein of Labbé. So this is how it would look like a venous infarction. So it doesn't fit into any arterial territory, and most of the venous infarctions will end up having some sort of a hemorrhagic transformation, which is the clue and the area of distribution to diagnose a venous infarction. So moving into some of the pulmonary imaging, then if you do a CT scan, then you would find a solitary pulmonary nodule. There are certain protocols that you need to guide or go through of a follow-up of a solitary pulmonary nodule. But if you see a nodule, it's well defined, it's very unlikely to be a primary lung malignancy. But when you see very carefully, you can see a hypodense. On CT, if it is hypodense, it has to be air or fat. So when you have a fat within a lesion, you tend to be a benign lesion, and you need to confirm it without doing a biopsy, which is quite invasive for a benign lesion. So you would do what you call in-phase and out-of-phase imaging, and on the left lower, you would see there's a signal dropout within the lesion, which is dark on the MR out of phase, which means it has clear fat within, and you can leave this nodule without touching. And when you can confirm with MR rather than just doing one imaging modality. Again, when you have any doubts on CT, there's on the subacarinal level, there's some sort of a soft tissue density, but you're not sure whether it's active or just a benign lymph node. Then if you do a MR image with T2 fat set, that you could say it lights up, and that means it's an active lymph node. And this can save a lot of time and a lot of discussions debating on whether this lesion is really needs something to be done. And of course the PET scan is the ultimate, but sometimes even the PET can be negative at certain instances. So just diagnosing pulmonary embolism, which is quite easy on CT, and you can see there are a lot of saddle thrombus on the right top corner on the main pulmonary artery going into both pulmonary arteries, which is quite easily diagnosed. And nowadays with the available new techniques, you can diagnose the perfusion of the lungs or the infarcted area due to the pulmonary embolism, which is, I think, they have just started doing at NHSL as well. And make sure when you are interpreting a pulmonary angiogram that whether it was done correctly, because if you look at the left top corner image, the pulmonary artery is more denser than the aorta, which is the correct one. Ideally, it shouldn't go into the aorta, in fact, but if you see on the right corner, that you can see that this is also a pulmonary angiogram, but the aorta is more denser than the pulmonary artery, and this will lead into a erroneous diagnosis when you diagnose as pulmonary embolism, which is in fact within the pulmonary veins. Another developing field is try and do MRCP and CT combo studies for if you're thinking of a biliary problem, because either of two are contributing to each other, where you would see in the top hand corner the diagnosing of a biliary calculus is quite difficult and it's quite demanding, and if the patient is not that cooperative, if you have a lot of motion artifact, it could be even just a artifact. But when you do an MR, you would see very nicely within the bile duct that there's a filling defects causing this duct dilatation. So the trend is towards just not to do one study, but to do a combination with limited protocol. So we'll have a sensitivity and specificity of quite a higher level on diagnosis of biliary pathology nowadays. And on the other side of the coin, where you would see on the top hand corner, this is in fact a case that I did very recently. I thought there was no filling defect in the MR imaging. So I thought, in fact, the patient had chronic pancreatitis with duct dilation. So the impression was whether the patient was having a periampullary or a head of the pancreas tumor for the MR. But we end up doing a CT where you would see that there's a very nice calcification at the, right at the ampulla causing this duct dilatation. So it's always contributing, because the MR, you don't do a volume acquisition, you do a series of limited slices. So if the calculus is less than 5 millimeters, you might miss if the calculus falls within that slice gap. And moving on to some of the abdominal imaging, and quite interestingly that we can diagnose very confidently that the adrenal adenomas, which is called the adrenal adenoma protocol, you do a non-contrast, then you do an arterial and a delayed imaging at 15 minutes, where I would see that in the arterial there's enhancement with definite wash-off in the delayed imaging, which is quite diagnostic for adrenal adenoma, and you don't need to do any biopsy or other investigations to make sure that there's no malignancy. But on MR imaging, that you can see that this is called in phase and out of phase. In the out of phase, there is clear signal dropout on the left adrenal gland compared to the in phase. That means that the lesion is having a good amount of fat within, and this is a pure diagnosis of adrenal adenoma is confidently made with confidence, so you don't need to do any biopsies in these cases. And moving on to some of the hepatocellular carcinoma, this is one of the, I think, if at all, it will be the only cancer in the world that you don't need a biopsy, where you do it just radiologically, but you need to do a proper 4-phase CT to diagnosis, because some of the lesions get enhanced very early, some of the lesions get in the early arterial, and then almost all will have a wash off in the delayed or venous phases. So, so you don't need to, if you do it diagnostic where the patient is having cirrhosis and you do a correct CT imaging, you would be able to diagnose this liver lesions and embark on treatment. Do I have more time, or just finish? Yeah. Okay. Just one slide I just want to highlight. Just 1 minute. I just want to bring up this one, because there's a new thing called whole body DWI, where you would see a lot of things that you can be diagnosed with this whole body MR DWI, where you would see osseous or non-osseous cancers, a tumor burden in DWI, and especially it is coming up in multiple myeloma, where it could be a new gold standard for diagnosis of disease burden, where even the PET scan on the middle, you would see there's not much of lesions, but on the first image where DWI is concerned, you would see a lot of tumor burden. Thank you. Since it's time is up, I will stop it there. Thanks.
Thank you, Dr. Ganevatta, for your informative and interesting lecture. I'm sure the audience will have some questions for him, but we will leave them at the end of the session. May I invite the next speaker? Next speaker is Dr. Aruna S. Pallewatta. He's the consultant radiologist at National Hospital of Colombo, and he's an honorary lecturer at Faculty of Medical Sciences in Colombo, as well as KDU. Over to you.
Thank you very much for the introduction. Good morning, ladies and gentlemen. First of all, I would like to thank the President and Council of the Sri Lanka College of Internal Medicine for giving me this opportunity, and it's my pleasure to be here. So my topic is on clinical radionuclide imaging, and it's actually, again, a field by itself. So I will try to concentrate on what is relevant for internal medicine and try to tell something which will be useful for your day-to-day practice. So first, what is radionuclide imaging? Actually, you heard about CT and MRI and other imaging modalities from Dr. Ganewat in the previous lecture. Those are mainly a kind of anatomical imaging and not much for the function. But this radionuclide imaging is mainly concerns with the function of an organ and also assessment of the physiological function of an organ, and also it has the ability to study the disease activity. In pure radionuclide imaging, the anatomical detail is not so clear. That's why we now the latest trend is to have hybrid imaging, where we can have two imaging modalities, CT or MRI, combined with radionuclide imaging. So we'll have hybrid imaging to get over that deficiency of poor anatomical detail. And here, unlike in CT and MRI, where we give radiation from outside to the patient and visualize what is being filtered through the patient, here we give the radioactive substance to the patient, either parenterally or orally, and then we depend on the energy emitted by the patient, which is detected by these cameras here. What you see on the right hand side is the gamma camera which we have in our hospital, and other one is the PET CT scanner which we have. So with them we can detect the energy emitted by the patient. And here we use gamma rays, which is product of radioactivity, and also some particulate radiation like beta particles. And for PET CT we use positron emission, which is high energy and more specific. So next I would like to tell you something about the medical radioisotopes, because radioactive substances there's a very large number of radioactive substances, and medical radioisotopes are generally of low energy, and also they should be able to be combined with what is called this radiopharmaceutical. Radiopharmaceutical is radiopharmaceutical is what is substance which will carry the radionuclide substance into the target organ we want. Now, for example, there is a radionuclide here, and it's combined with a carrier, so it will go to the target organ. And in medical radioisotopes, in this country we use technetium-99m, which has a 6-hour half-life, and that is important because we don't have any radionuclide producing facilities, so we get it as a generator, which we can use for about 14 days. Then we have radionuclides of gaseous form, like technogas, this technetium gas, xenon and krypton. And also we have things like indium-111, gallium-67, and various forms of iodine, iodine-125, 123, and iodine-131. Iodine-131 is the only one which is available in this country. Then we use also fluorine-18 for PET imaging, which has a half-life of 110 minutes, and it is always combined with fluorodeoxyglucose, almost always combined with fluorodeoxyglucose, because it will analyze the glucose metabolism of a tissue. Also, we have another PET tracer, which is gallium-68. When we combine with dotatate, we can use for neuroendocrine tumors, and also PSM is for prostate. So, other important thing is radiation doses are higher with PET. So, the energy is about 511 kilo electron volts, while technetium is about 140 kilo electron volts. So, in this I show you my first case. Now on the right hand side, the images you see are the normal bone scan, and on the left hand side you will see an abnormal bone scan which shows when you compare to the normal one, you will see there is a definite diffuse and patchy increase of activity in the skeletal system, in the ribs, in the pelvis, in the limbs, skull, etc. So this is the condition known as this is the appearance known as a super scan, where you get a diffuse increase. And you can see the similar thing, the previous case of prostatic carcinoma metastasis, then you can get with the hyperparathyroidism, you can get the Paget's disease. And actually, here, the radioisotope, as I mentioned earlier, uses technetium, but it's bound with what is called the MDP, or methylene diphosphonate. It will accumulate areas of osteogenic activity. So wherever there is oxygenic activity, you can do this imaging. For example, you can use to see bone infection, trauma, like stress fractures, then non-accidental injury in children, and to detect malignancies as in the case I just showed you. So this is a case of infection, to how you use that for detect early osteomyelitis. You can see this is a dynamic scan. So you start imaging as well as you inject the tracer into the patient, and you can see in the right ankle there's areas of increased activity which will further enhance in the delayed images. So this is the appearance what you get with the infection. This kind of things is very difficult to see with normal anatomical imaging, either CT or MRI, because you will see some changes, but you don't know the activity of the disease. But this helps you to see whether it is acute or chronic, or whether the disease has healed. So again, this is about infection, but this is soft tissue infection. If you see the first row of images, that is you have plain X-rays, CT and MRI, and also ultrasound, where you see some changes in the spine, where you see some marrow edema, but still again we don't know the activity of the disease. But here we can use radionuclide imaging here using technetium, or there are other substances where we bind that with the white blood cells. So wherever there is infection, you know the white blood cells will go. So you combine either technetium or indium. Indium is the best one to be combined, and it will be go to the area where there's inflammation. So you know whether there is active inflammation or not. As you see in the image in the middle here, there's increased activity. Indium is difficult in our setup because it's a very short half-life, and you have to have a cyclotron just next to your hospital if you are going to use it. But other thing you can use is gallium-67, which is related to lymphatic activity. So when there's an infection, again you can use that gallium citrate per se. You can use for detect areas of infection, and also you can use that for detection of lymphomas. Then nowadays we can use PET imaging also. Now, as you see in this case, when you PET imaging depends on the glucose metabolism, and when there is activity in that hypermetabolism of the tissues, we know the disease is active. So here they have combined that with the, you can see in the picture is a pure CT image, picture C is a fused image, picture B is a pure PET image. So both are combined to show us the anatomical location and also the activity on the fused image C. And this is also useful for spinal infections, diagnosis of musculoskeletal infection and pyrexia of unknown origin. This is very helpful. And the next case is for the technetium-99 study tagged with MEG3 or DTPA. This MEG3 and DTPA are substances which are almost nearly 100% undergo glomerular filtration. Therefore, this scan can be used to see the renal excretion, drainage, and also function. Therefore, you see, as you see, these are posterior images. So on the here you see some images, and you can see the left kidney. The right kidney is normal with normal drainage. Left kidney has only a rim of activity. And if you go to the graph, the graph on top is the normal right kidney, which shows normal pattern excretion, while right kidney shows left kidney shows impaired function. So here you have an assessment of the function and drainage, and you know which kidney is normal and which kidney has poor function. Then you can see in this image, after patient has undergone surgical treatment for relief of obstruction, you can see both kidneys are excreting well. So this is good for assessment of the renal drainage and the function. Therefore, you can use that for diagnose things like PUG obstruction, to assessment of the kidneys in the renal donors, and to get the relative renal function, GFR, and also it is important to detect ectopic locations of the kidneys. And this is also quite important, I think, for you, to diagnose of renovascular hypertension, renal stenosis. We have many anatomical modalities to detect the renal artery stenosis, like either we can do MR angio, we can do DSA, we can do CT angio, as you see in this case, and you see the area of stenosis part, but still we don't know how functionally significant that is. For that we can use the capital study, and you can see the two graphs on the right hand side which are pre-captopril, and you can see one on top is the left kidney which is suspected of having renal artery stenosis, and the normal one on the bottom in the blue is the right kidney, and you can see right kidney is normal, left kidney has some impaired function, and after giving captopril, the images on the right hand side on the left, on the right hand side after captopril, and you can see there is increased more impaired function on the left kidney. So after giving captopril, the function has dropped. So in that, in the situation, we can diagnose that there is a clinically significant functional drop after captopril. So patient has significant functional renal artery stenosis. Then pulmonary embolism, actually Dr. Ganevath also mentioned about this. Now the main modality nowadays is multi-detector or CT, and however there are some cases which, even though you see the thrombus, we don't know how severe that is, or whether lung function, how great, how to what extent it affects the lung function. So for that you can use radionuclide studies, and also when there's a doubt with the anatomical imaging modalities, you can use this. So we do what is called the VQ scans. This is the picture of a VQ scan. So ventilation part we do with technetium gas, or you can use xenon, but here which technetium gas is the main thing. So image on your left is the ventilation scan, which is normal, and on the right hand side you do the perfusion with technetium labeled macroalbumin particles. So you can see there are multiple defects on the lateral aspect of the right lung. These are the posterior images, and so you know there's a defect which are normal ventilation but perfusion defect. So this is a typical ventilation perfusion mismatch. So you can diagnose significant clinically significant lung infarction and pulmonary embolism with this. And I think the similar images you saw in the previous lecture as well. Here you can see on the left hand side, you can see plain X-ray and CT with the thrombus and infarcted area. And what you see on the right hand side is the lung perfusion mat. Actually, currently we have a machine which is capable of doing this. So even if we don't see the thrombus properly, we can see the area of lung infarction by doing the iodine mapping using the spectral imaging. So this is actually our machine. We can see the area of infarction. So this is more sensitive to detect areas of lung infarction if you do the iodine mapping. Then radionuclide scans are also very useful for detection of thyroid diseases and goiters. And we can use technetium-99m, which we use very commonly in this country, which is taken up by the thyroid. But also you can use iodine, which is not only taken up but also organified. So if you want to study about the thyroid function of uptake and both organification, you have to use iodine. And in this country we have iodine 131, but it is very high radiation dose. So it is generally we don't do it. Iodine 125 and 123 is not available here. So we usually generally we use technetium, which can be useful to exclude whether lesion is a cold nodule or a hot nodule, and to detect things like thyroiditis, Graves' disease. Technetium-99 you can use, and also to detect ectopic thyroids like lingual thyroids, you can use technetium. Iodine you can use for especially follow-up of follicular and papillary carcinomas, you can use iodine. And also if you want to do the proper uptake studies, you have to use iodine. And this is the case, some images here. You can see here the cold nodule. You can see a photon deficient area in the left lobe, upper pole, And in the middle image, you see the diffuse increase, which is what we see with the Graves' disease or sometimes with the thyroiditis. Then the one on the right hand side is a hot nodule. Actually, you see a area of very high uptake in the lower pole of the right lobe, but the rest of the gland you can't see because it's suppressed by the increased activity of the hot nodule. And this is also quite important, I think. This is a case, this is a patient with melena and low hemoglobin and suspected of gastrointestinal bleeding. For these situations also you can use radionuclide imaging. Here what we use is technetium 99M tagged red blood cells. So when you inject the red blood cells into the patient, it will go wherever the blood goes, like you can see liver, spleen, blood vessels you can see. When there is a bleeding from the bowel, whether even though it's intermittent, you will see with this scan as you see here, and with time, because you are doing serial images from 5 minutes up to 30 minutes, 1 hour you can do. So even when there's intermittent bleeding, so slow rates you can see with diagnose with this. But the main problem with this is the anatomical detail is poor compared to CT angios and DSAs. So you can see in this situation there's a CT angio and a DSA where you can see exactly where the AVM is, arteriovenous malformation is. But to detect by CT angio and DSA, you need some active bleeding at that point when you are doing the examination. But for nuclear medicine, you are doing over a period of time, and therefore even very slow bleeds you can diagnose with red blood cell studies. And this case is 51-year-old female with abdominal pain. This is a different case. You can see on the CT there has been a hypervascular pancreatic head mass, so suspicious of a neuroendocrine tumor. Here what we use is indium 1,1 labeled octreotide. As you know, octreotide is a somatostatin analog. It is therefore you are using peptide based imaging, and it will go and bind with the somatostatin receptors, which are higher, which are expressed in high concentration by the NETs like insulinoma, gastrinomas, etc. And in this patient, you can see the you can see in the over the pancreatic region, you can see area of increased uptake, which is increased uptake, which is due to uptake by the tumor. Then normal excretion is seen in the kidneys, which this is the abnormal area, and you see the normal uptake in the kidneys, but this is the abnormal area in the center. So that is a suspicious of a NET. And here you can see it's a kidney. This is the abnormal area. In addition, there is an area of high activity in the liver, which is, these are posterior images, so which is suspicious of a metastasis. So generally you combine octreotide with indium 111. You can, it's difficult to combine with technetium, so it's difficult for us to do here. And however, there are other methods to detect these neuroendocrine tumors. Now you see this is a iodine 131 MIBG scan, which has been traditionally used, but only problem is it is a low sensitivity, as you see in this case. You can use PET. PET generally have some affinity to metabolic activity, glucose metabolism of these lesions, so you can detect. But the ideal what you use is the gallium-68 labeled dotatate, which is again a somatostatin receptor, they have affinity to somatostatin receptors, but this gallium-68 is also a PET tracer, so it is very sensitive for this kind of NETs. And so with that, I just tell you something about the PET-CT. PET-CT actually generally, first I show this slide. We combine PET tracer, fluorine-18, usually with glucose. And as you know, glucose has a active transport system into the cells. Same way, fluorine labeled fluorodeoxyglucose is taken up by the glucose transporter system into the cells. And then it is converted to FDG6 phosphatase by the hexokinase and similar to glucose, but glucose after that will undergo the glycolysis and undergo the pyruvate pathway, but FDG stops here. It doesn't undergo the glycolysis, and therefore all the FDG will accumulate in the cells. So this is the basis of detection of metabolic activity by PET. So you can use wherever there is increased glucose metabolism, you can use it. So one of the best uses is PET-CT in lymphoma. Lymphoma you don't use PET for diagnosis, mainly for staging and see the detection of lesions and follow-up. And you can see this is the case where you do for follow-up. You can see serial images. You can see with the treatment the lesions are disappearing. And also you can use to detect where the lesions are. So you have a baseline imaging in the follow-up. And the lesions which have high levels of glucose metabolism are like colorectal cancers, lung cancers, lymphoma, esophageal cancer, and melanomas, head and neck cancer, generally useful in the initial stage and restaging. But things like breast cancer, not so sensitive. And there are some non-oncologic applications also, like detection of infection and inflammation. I showed you one slide earlier, like PUO, bone infection, and sarcoidosis, and especially in myocardial perfusion, we can use that for viability of the myocardium. We do MRI, we do SPECT-CT, but we can use this is more sensitive compared to SPECT-CT, the PET-CT for myocardial perfusion. And also you can use in the neurology for neurological abnormalities like detect seizure foci, dementias, you can use it. And finally, PET imaging. Something more about PET imaging. PET imaging is not only FDG, as I mentioned earlier. You can use in various situations. It depends on what you combine fluorine with. And you can use that even for tauopathies like Alzheimer's, corticobasal degeneration, PSP, etc. Where there is neurofibrillary tangles, there are substances which can go and bind with them. So one substance is this AV1451, which is a second generation PET ligand for tau ligand, and this will show you where the distribution of where the deposition of tau proteins. So this is Alzheimer's, this is corticobasal degeneration, and this is progressive supranuclear palsy. So when you compare the control, you know where the abnormal is and where the abnormal deposition is. So this is one of the uses, and there are many other uses developing as well. These are I was talking about the established uses of PET imaging. So thank you very much. I hope I was able to give some insight into this field of radionuclide imaging. Thank you very much.
Thank you, Dr. Anura Palewatha. That was an excellent talk. Next speaker is Dr. Suresh Fernando from UK. The topic is how I use CT coronary angiogram in clinical practice. So he is a consultant radiologist, Queen Elizabeth Hospital, NHS Trust, UK. He is an associate lecturer at School of Medical Science, University of Cambridge, and the honorary senior lecturer, School of Health Sciences, University of East Anglia, and college tutor, Royal College of Radiologists. Over to you, Dr. Suresh Fernando.
Good morning, everyone. I'm going to talk about cardiac CT or coronary CT angiography in clinical practice. By trade, I'm a radiologist. I work in the UK in East Anglia in a small coastal town called King's Lynn. Within the next 20 minutes or so, I'm going to talk briefly about the history of cardiac CT, basics of CT and cardiac CT image acquisition, normal and anomalous anatomy of coronary arteries, calcium scoring, and how to interpret the coronary arteries and how to assess the plaques, and also significant non-coronary findings that we encounter on cardiac CT. In 1969, Sir Godfrey Hounsfield developed the first experimental CT scanner, and it was 1971 when they installed the first clinically useful CT scanner in London. But these scanners were very slow. It took several hours to image a single body part like a brain. It was not possible to image a fast-moving organ like heart with those CT scanners. So the first attempts of cardiac CT was made in late 1990s. Since then, there was very rapid advancement of the CT scanners, the equipments, and also the software. So it became widely available, and then more and more centers worldwide started doing cardiac CTs. The accuracy and the reliability of coronary CT angiography was validated in 2008 with 3 controlled clinical trials. So this is the basic structure of a CT scanner. You have got an X-ray tube at one end which emits beam of X-rays which go through the patient and get attenuated to a certain degree as they come out, and then they are received by a detector at the other end of the gantry. So if you remove the outer covering of the gantry, it looks something like that, very complex, and this whole thing spins around the patient at a very fast speed, a few times a second. It takes only 180-degree spin around the patient to acquire a complete set of images of that particular segment of the patient body. Once it's done, the patient moves forward by a few millimeters or centimeters, and the CT does it again, go around the patient. You can keep gaps between the segments that you acquire like that. If you do that, we call it a pitch more than 1. If you don't keep gaps and if you don't overlap, that will look something like that. So no gaps between segments of body parts, then we call it a pitch of 1. If we overlap the segments, then it will look something like that. Then we'll call it a pitch of less than 1. The first generation CT scanners were single detector. That means it has only one single row of detectors. Since then, most vendors worldwide started developing multi-detector CTs. That means they had more than one detector rows. So 4, 16, 32, 64, and now we have got a 320, a giant multi-detector CT scan. So what does it mean to the study if you have multiple detectors? Let's have a look at this one, a single detector. If you have a single detector, the width that we can cover at a given time is very small. But if you have multiple detectors, then we have a wider coverage. So given, let's say if you are scanning the heart, at a given time, we can cover a bigger portion of the heart with these multiple detectors. Again, another diagram to demonstrate that one. If you have a bigger detector which can cover the entire heart, then we can image the entire heart in one cardiac cycle. But if your detectors are smaller in width, then we have to use multiple segments or multiple blocks of the heart using different adjacent cardiac cycles to get a complete image of the heart. If you get a perfect overlap between the adjacent segments, if the heart remains the same, then we have a perfect clear picture. If the heart is different in the subsequent beat, the cardiac cycle, then this segment and the following segment do not overlap properly. Then what will happen? You end up having something like that, a step between segments. Like here, this is the sternum from a lateral view, and this is a coronary artery, and you can see there's a step between the upper segment and the lower segment. So this is called a step artifact. There are several technical terms that we come across with CT. Two of them, most important thing would be temporal and spatial resolution. When we talk about temporal resolution, this is like the shutter speed of a camera, the ability to resolve the fast moving objects. If you have a higher shutter speed, then you can get a clearer picture of fast moving objects. As I mentioned earlier, it only takes 180 degrees spin around the patient to acquire a complete set of images of that particular segment of the patient's body part. So if your gantry speed is, let's say, 330 milliseconds, the temporal resolution would be half of it, 165 milliseconds. It's important that your temporal resolution is less than the length of the diastole to take clearer pictures of the heart. There are dual source CT scanners. So what it does, they have got 2 cameras and 2 detectors. So it takes only 90-degree spin around the patient to take complete set of pictures. So if that is the case, their temporal resolution in this example would be somewhere around 80 or 85 milliseconds. The next one to consider is the spatial resolution, which is the ability to discriminate 2 adjacent objects from each other. As you can see on this picture, on this diagram, the dots on this side A are a little blurred, but dots on this side C are much clearer. That means this scanner has got much better spatial resolution compared to A. This slide compares the spatial and temporal resolution of various imaging modes, let's say CT, MRI, PET-CT, and catheter angiography. So generally, the spatial resolution of CT remains somewhere around 0.5 to 0.65 millimeters. Okay, let's move on to cardiac CT. So what do we need to do cardiac CT? So we need high spatial and temporal resolution. We need to synchronize the scanner with the patient's cardiac cycle. We need to have some software, some reconstruction algorithms, and we need some patient factors. So who would be an ideal patient for CT cardiac angiography? Someone who has got a low heart rate, which has no arrhythmias, low BMI, easy venous access, no intravenous contrast allergies, and no contraindication for beta blockers or GTN, and someone with a good renal function so we can administer IV contrast. So before we move on to the post-contrast angiographic phase, we acquire non-contrast phase image of the heart to assess the calcium. Using an algorithm, we can assess the calcium scoring for each artery. So it takes into account the density of calcium and the area of involvement. So this calcium scoring is given for individual artery and also the total calcium scoring for the entire coronary circulation. If someone has less calcium or no calcium and that patient is asymptomatic, the risk of coronary heart disease is very, very minimal. If someone has high calcium scoring and the patient is symptomatic, then the risk of having coronary disease is very high. So once we have done the calcium scoring, we administer IV contrast and take the images of the heart. We have to synchronize the patient's cardiac cycle with the CT scanner. If you don't do that, it's called non-gated, and the images are like that, very blurry. If you gate the cardiac cycle, then it's called ECG gated imaging, and it end up having very clear pictures of the heart and also the coronary arteries. So there are 2 main types of ECG gating, prospective and retrospective. As you know, the motion of the heart during different parts of the cardiac cycle is different. The least amount of motion is seen during the end diastolic part of the cardiac cycle. So we can use that information when we consider our gating. If your patient's heart rate is low, let's say less than 60 beats per minute and regular, then we can apply this method. It's called prospective acquisition. So what you do, you select only the end diastolic part of the cardiac cycle to acquire the images. So we acquire a set of images of a particular segment of the heart, and then patient moves to the next segment of the heart. Then we acquire another block of images, and so on. We have to use 3 or 4 cardiac cycles to acquire the entire pictures of the heart. Then you stitch them together to produce a perfect picture of the heart and the coronary arteries. So this method, you can call it step and shoot method or prospective gating. The advantage is you use only a small dose of radiation to the patient. The disadvantage is, as you do not have data regarding the rest of the cardiac cycle, you cannot assess the function or the volume of different parts of the cardiac cycle. If your patient's heart rate is high and or irregular, then we cannot use this method. Then we have to use the other one called the retrospective acquisition. That means you have to turn the x-rays on during the entire part of the cardiac cycle, and again you have to use 2, 3 or more adjacent segments to acquire the complete set of images of the heart. The disadvantage is that you use a big dose of radiation to the patient. The advantage is, as you have data throughout the cardiac cycle, you can assess the volumes, you can assess the function of the heart in addition to the assessment of the coronary arteries. There is a hybrid mode, what you see here, what you call ECG gating with tube modulation. If your patient's heart rate is low and regular, you can turn it on at a given phase of the cardiac cycle. Rather than turning it off completely, you can keep it low during the rest of the cardiac cycle. So we have clear images to assess the coronary arteries and some data to assess the function and volume of the heart. So this demonstrates how we acquire images slab by slab or segment by segment to cover the heart. If you have a bigger detector that will cover the entire heart, then you do not need multiple slabs. You can cover the entire heart in one go. As you know, this is Prince William, the future King of England. What he's doing in front of a bigger gathering is probably questionable. But if you look at him from a different angle, you would realize your initial thoughts were incorrect. So it's very important that you have a look from different angles before you come into a conclusion. This applies to cardiac imaging as well. Once we have done the cross-sectional imaging of the heart, we don't use this set of data to assess the coronary arteries. What we do, we post-process them using some softwares which are available, and we produce this type of curved images for different coronary arteries. We can rotate these images and we can have a look at the arteries from different angles to assess the arteries in detail to detect any narrowing or any disease segments. To recap, this is the normal anatomy of the coronary arteries, how they arise. They arise from this little bulge in the aortic root, what we call sinus of Valsalva, and there are 3 coronary cusps. The right coronary originates from the right coronary cusp, the left one from the left coronary cusp, and the remaining one is the non-coronary cusp. The normal anatomy of the coronary arteries, the left main originates from the left coronary cusp, and it divides into normally to 2 branches, LAD and circumflex. From circumflex you can get other branches like OM branches or obtuse marginal branches. From LAD you get some septal branches and diagonal branches. Sometimes the left main can trifurcate. In that case you will have a 3rd branch coming from the middle called ramus intermedius. The right coronary artery comes from the right coronary cusp, and it gives few branches like coronal branch, acute marginal branch, and usually continues as the PTA and posterior lateral branch to supply the posterior segments of the heart. There are different types of anomalous origin of coronary arteries. There are a few types, as you can see here, but the most significant type or the malignant type is the interarterial course of the left main. As you can see here, the left main goes in between the pulmonary artery and the aorta. So these two can squash this artery to a significant level, and that will result in sudden cardiac death. The other anomalies include high take of coronary arteries, as you can see here, and sometimes can have an intramural course. That means the coronary artery travels through the wall of the aorta before it comes out. And there are rare varieties called L kappa, that means the left main originates from the pulmonary artery, or R kappa, that means the right coronary originates from the pulmonary artery. And they can have some significant consequences. And this cap is alpaca. The coronary arteries usually travel in the epicardial space, surrounded by various amount of fat. But sometimes the artery can dive into the myocardium like that. And that phenomenon is called myocardial bridging. Mostly, if the bridging is a short segment, they will not have any clinical outcome, any importance. But if the bridging is long like that, and that segment of coronary artery can get compressed, squashed during the systole, so these people can have some clinical symptoms. So once we have done the imaging, once we have done the post-processing and got the curved images of the coronary arteries, then we can start assessing these arteries. If there is any narrowing or stenosis, we can report them using some standard guidelines. So generally, if the stenosis is less than 24%, we can call them minimal stenosis. Anything between 25 to 49 is called mild stenosis. 50 to 69 is moderate, and more than 70% is severe stenosis. For the left main, anything more than 50% is called severe stenosis. There are two main types of plaques, what we call soft plaque or calcified plaque. If the plaque is like that with low density material, and it's called a soft plaque or low attenuating plaque. And if it's high density like that, it contains calcium, so these are called calcified plaques. If you have calcium in a plaque, it can cause artifacts. If we have a look at this example here, if this is your calcium plaque, this portion of the plaque goes into this voxel. So when this voxel averages out its density, that will look something like that. Similarly, this part of the plaque goes partially into this voxel, but when it averages out its density, that will look something like that. That means the actual size of the plaque will look much bigger on the CT image. So what it does to the coronary artery? If you have a bigger, quite chunky calcium plaque in the coronary artery, that plaque will look much bigger than its actual size. That means the lumen will look much smaller than its actual size. So we can overestimate the degree of narrowing in the presence of high density calcium plaque in coronary arteries. We can also assess the finer details of the plaque. It's important to identify high risk plaques. If you have certain features, for example, if you have a low attenuating plaque or soft plaque like that, it's a high risk plaque. And if you have a positive remodeling, that means there is active inflammation in the subintimal space of the artery, that also high risk, because that can rupture into the lumen. If you have spotty calcium like that, spots of calcium in the background of low attenuating plaque, this is also a high risk plaque. And then the napkin ring sign, that means if you have a low attenuating plaque surrounded by a thin rim of high attenuation, and this is also a high risk plaque. So they are vulnerable, they are unstable plaques. Okay, we can also use cardiac imaging to assess the coronary bypass grafts. So as you can see on this picture here, this is the aorta, and you can see a vessel coming from the superior part of the thorax coming down towards the heart. So this is a LIMA graft, or left internal mammary artery graft. And you can see two more grafts here coming from the aorta. So these are venous grafts, and in this case these grafts were occluded just after their origin. There is a reasonably a novel technique called CT FFR or CT fractional flow reserve. This is a non-invasive assessment of the fractional flow of the coronary arteries using CT data. If you have a question about the functional significance of a particular narrowing stenosis of the coronary arteries, we can send the data, these images, to a company in US, and using a supercomputer they can assess the flow reserves, the pressure and flow variance across a particular narrowing, and provide us with some useful information. We also come across some surprises on cardiac CT, some significant non-coronary findings. For example, on this image here, there was a tumor, left atrial myxoma on cardiac CT. In this case, there was aneurysm and pulmonary embolism on cardiac CT. And you also have to look at the corners of the CT scan when you take the images. And in this example, there was a small tumor in the left lung. And finally, this is the Toshiba 128 slicer scan. This is what we have. We've got two of these machines. One of them we mainly use for A&E and inpatient imaging. The second one is used for outpatient cardiac imaging, CT coronographies, and also for other CT guided intervention. Okay, thank you very much. I was planning to join online initially, hence the video, but I had the chance to come in person at the last moment. I don't know if we have any time for questions.
Thank you, Dr. Fernando, for your excellent talk, and thank you for coming in person here, at least at the last moment.
My pleasure.
I think we can. Can I invite other two speakers onto the stage? I'm sure you will have some question for the experts. Do you have any question? Can I ask one question for Dr. Ganiwath?
Yes.
So one major problem we encounter during clinical practice is giving contrast to patients with renal impairment.
Yeah.
So I'm sure there are no cutoff values for creatinine, but there are various protocols which have been used. Is there any standard protocol in the patient preparation before a contrast CT in a patient with renal impairment?
Actually, we ask from our nephrology guys for help in that regard. But mainly what all the studies have shown is to adequate hydration is quite enough. You don't need the neck protocol, or really if the patient is on metformin, you need to stop the metformin and wait for the serum creatinine levels and then restart the metformin if the patient is on metformin. And when you have some certain guidelines of high serum creatinine, you ask from our nephrology colleagues for help in that regard. But usually the adequate hydration 4 hours prior, and when you give the contrast, then you have to rehydrate the patient at least for 4 hours adequately. That quite good suffice with the serum creatinine levels. But if the patient is on dialysis, you plan the study and then you do the dialysis next day or soon after the procedure. But there's no hard and fast guidelines as such, because it depends on the nephrologist that you are referring. Usually the hydration is quite adequate.
Okay, thank you.
Yeah, Doc, I just want to congratulate all three speakers. Dr. Ganiwath, now I just saw some images on venous infarcts, and they look like hemorrhages to us.
Yeah.
So how do you differentiate a venous bleeding into a venous infarct from a peripheral hemorrhage due to amyloid angiopathy?
Yeah, usually if it's amyloid, it's quite difficult on CT, but if you do a MR, you would see a lot of microhemorrhages in addition to the larger hemorrhage itself. But if it's only on CT, it's quite difficult to differentiate. But basically what you see the hemorrhage, you will get the area where you would expect it, as I shown in the venous infarction areas. If it is that territory, you would suspect it could be a venous infarction rather than a peripheral ICH. And generally, if it is a uncontrolled hypertension, you wouldn't get a peripheral ICH other than this, the amyloid angiopathy. So it's usually the central and the basal ganglia. You would get the hemorrhages if it is just a uncontrolled hypertension, ICH. But if it is in a territory where you would see in a venous infarction, either on the parasagittally or you would see in the temporal fossa, then you would have to suspect whether it's a venous infarction. And then you will embark on venogram and to exclude any venous thrombosis.
Thank you. The last question from the virtual audience. In a patient with suspected plasmacytoma who cannot undergo MR imaging due to past fracture surgery with internal fixation and high serum creatinine, is PET imaging a good alternative? That would be the last question.
Actually, in multiple myeloma and plasmacytoma, PET is not that sensitive. In this patient, now the one issue is actually the patient has internal fixation. If it is not, if there is MR compatible, we can go ahead with MR imaging. So that first we have to find out whether the patient has the internal fixation is MR compatible. Otherwise, I think even PET we do a CT. Generally in our protocol we do a contrast CT. So we can do a non-contrast CT in that case if because of the high serum creatinine. But PET is I must stress that PET is not very sensitive for multiple myeloma. So that is one of the situations. It's not that sensitive.
So at the interest of time, we have to wind up. So may I invite Dr. K.T. Sundaresan to present the certificates of appreciation. Dr. Iranga Ganevatta. Dr. Arunes Pallevatta. Dr. Suresh Fernand. Thank you for all the speakers for coming here and delivering the lectures. And this concludes the radiology symposium.